For my topic, I chose plyometrics and older adults. The clinic that I was placed in was an outpatient setting, and in our outpatient setting, we had a majority of an older population. And in that older population, I did not really see any plyometric interventions with that population. So my CI and I, thought it would be interesting to see if plyometrics would be something that benefits the older population and something that they could start using more of with their patients. So the question that I asked was, for my PICO question, was, are plyometrics as effective in increasing strength and function in older adults as compared to traditional resistance training? So the study that I found was an age-adapted plyometric exercise program in older men. So there were three groups. There were a plyometric group, a traditional resistance training group, and a walking group, which was a control group. They looked at 4 outcome measures. They looked at force production and strength. They looked at power. They looked at jump performance, and they looked at functional performance. The study was a 12-week study. 40 men participated. They volunteered to participate or agreed to. They were between the ages of 65 to 80 years of age, and they were all randomized into those 3 groups. 14 were in the plyo group, 12 were in the resistance training group, and 14 were in the walking control group. Some exclusion criteria that they had were cardiovascular disease, neurological disorders, cognitive malfunction, severe knee or hip problems, history or rupture of Achilles tendon, and someone who currently already engaged in resistance training. And so what they found was that in the 1 rep max, both resistance training group and the plyometric group improved similarly. They also found that the resistance training group was the only group to increase in maximum force. So that was a maximum voluntary contraction. And then the plyo group improved more in squat jump height. They improved more in power. They increased their contraction time the most. And they improved the most in stair climbing. And they found that contraction power production increased as eccentric time decreased. And this was most improved in the plyometric group. They also found that the 10-meter fast walk and the 6 minutes walking distance, I got that mixed up. So the 10 minutes fast walk and the 6-meter walking distance improved similarly in all the groups. And so in the resistance training group, 1 dropped out because of low back pain. 3 dropped out in the plyometric group because of the muscle strain or knee pain. So those are all the things to take into consideration when kind of like prescribing these type of interventions to your patients. That there's a risk of low back pain and things like muscle strains and knee pain. Other adverse effects they found was muscle soreness, which wasn't something that prevented them from participating throughout the whole intervention. They continued to participate, but there was soreness, which we expected. And during the plyometric interventions, they found that the box of 30 to 40 centimeters was used in the beginning and caused the most strains and knee pain using that box. So once they decreased the box size to 20 to 30 centimeters, they found that those strains and knee pain and low back pain weren't as common anymore. So that kind of helped prevent some of those side effects. And they found that adherence in the plyometric group was pretty high, and their acceptability in plyo was pretty high too. So patients reported that they would continue to do plyometrics in the future, or would agree to do plyometrics in the future. And then most of them also completed the interventions, which was pretty good. And another thing to consider was that they were self-selected, so they agreed to this, so they were all essentially on the healthier side, or they had more of a motivation to participate. And then another thing that might be helpful to prevent injuries was that resistance training was not given before plyometrics. So if you combine both resistance training and plyometrics, you might see a better outcome. Well, we don't know that because that wasn't done in this study, but it's something that could be used in the future. The outcome or discussion questions that I asked them was 2 questions just to test their knowledge based on what I talked to them about during my presentation or the journal club, and then 2 more were for discussion and hearing from something from their history or their stories with their patients. I asked what loss is more pronounced in aging. I asked them if rapid force power or maximal force / muscle mass was lost the most. And the answer was rapid force and power. That is, you have a greater extent in loss in that component or that aspect of your body versus just muscle mass. So you lose power a lot faster than you do muscle mass. So that was pretty important. Another thing that I asked them was, what is the recommended height of a box for jumping exercises? And like I mentioned earlier, it was a 20 to 30 centimeters versus the 30 to 40 centimeter box. And then we just talked about how that decrease in box height would benefit patients in order to decrease, strains and knee pain, to make it more beneficial for their patients. So that was something that we found to be clinically relevant because it would help us to, create that baseline and that plan for their patients. Then I asked them if anyone ever experienced positive results from plyometric interventions, and a couple mentioned that they were currently attempting to do plyometrics on a leg press, and that they would continue to provide them these interventions to see if there's any further improvement with their patients. But most of them really weren't doing plyometrics. And then I asked if anyone had a patient that might benefit from plyometrics based on what we learned, and most of them agreed that plyometrics is something that they would try more of based on what we talked about. They just wouldn't do it as often because they weren't sure about the risk to benefit ratio. So after talking, they were more open to the idea of starting doing more plyometrics, starting at low intensity and then gradually going a little higher as they saw fit. And so my areas of strength that I saw for myself during this presentation and during the whole discussion was that I was able to connect this journal with their current practice. I felt like I gave them things to put into their toolbox, like the height of the box, what kind of population was used in the study, to help them get an idea of what kind of patients they have now that might benefit from the plyometric interventions. And things that I still have to work on is the connection between what the intervention outcomes were. So explaining more of the interventions in detail, like the evaluation and the results, I think I have to learn how to compress it into like a shorter amount of time to kind of like take advantage of the time that I have without overloading or oversharing details that might not be the most beneficial for this setting at the moment. I need to determine how to differentiate a journal club versus a actual PowerPoint presentation.